Alright, so we continue with our discussions of the pulmonary system. Okay, so whenever you see somebody who's 37 with shortness of breath, cough, hyperinflated lung, and then you see COPD features on X-ray on the pulmonary function test, diagnosis, this is alpha 1 antitrypsin, usually could be, because this causes COPD in young people, like around 37. That's pretty young. Okay, now another patients that come in with cough, dyspnea, okay, crackles, systolic murmur, clubbing, patchy ground glass opacities in the upper lobe. Okay, this guy would be older, 67 or so. Okay, and this one, what would be your diagnosis for this patient? This is called hypersensitivity pneumonitis. This is different from eosinophilic pneumonitis. This is hypersensitivity pneumonitis, usually caused by chronic allergen inhalation, birds, hay, hot tubs, acute flu-like symptoms, fleeting infiltrate, could subacute to chronic, could develop weeks to months, could cause cough, dyspnea, weight loss, pulmonary fibrosis. The way you diagnose it, there's a history of exposure, chest CT, ground glass opacities in the mid to upper lungs, causes serum. There's a diagnosis, usually you can do bronchoalveolar lavage, causes lymphocytosis and BAL, you will find that. Lung biopsy causes poorly formed granuloma, you can see that as well. Management, allergen avoidance, systemic steroid in severe cases, okay? This is hypersensitivity pneumonitis. So we have a bunch of things like hypersensitivity pneumonitis, eosinophilic pneumonitis, we have radiation pneumonitis as well, okay? Okay, now another case, you see like 44 man comes in with cough, productive sputum, you know, and then you see CT shows dilation, wall thickening of the right lower bronchi, you see fibrosis, consolidation, you know. And then they will ask what's the best next step in management, okay? How do you manage it? You manage it by serum immunoglobulin. You do. Why you do that? Because this could be bronchiectasis, okay? This is the best next step. Okay, so bronchiectasis now we're talking about could be caused by infection, you have dilation of the bronchioles, so causes thick, voluminous sputum, okay? And can be caused by airway obstruction, foreign body, cystic fibrosis, allergic bronchopulmonary aspergillosis as well. Autoimmune disease like Sjogren disease can cause that. You diagnose it by high resolution CT scan, and pulmonary function test you see obstructive pattern as well. And you check immunoglobulin, respiratory culture, bronchial obstruction. And the way you treat it, you address underlying disorder, like if there's immunoglobulin deficiency, you replace that. Chest physiotherapy would be a good thing to do that. Mucolytics, you know, this will thin the thick mucus secretions. Antibiotics to suppress bacterial overgrowth and treat exacerbation. Well, this would be a good thing as well, okay, for bronchiectasis. Okay. Now, this 20-year-old, another patient, 20-year-old comes in with cough, okay, dyspnea, and then they will have nighttime wheeze awakening, okay? Pulmonary function test is within normal limit. So how do you diagnose? Or best next step, how do you do that? In this case, you do a methacholine challenge test to know exactly what you're dealing with, okay? Because this one, it's called reactive airway dysfunction syndrome, okay? Causes chronic asthma-like illness after single high exposure to pulmonary irritant. Like single exposure causes chronic issues, okay? Usually within 24 hours happen. There's no pre-existing lung disease, and you see your airway obstruction or pulmonary function test, and positive methacholine challenge test after exposure. So this is a way to diagnose that disease, because treatment may improve when help the steroid, but others respond poorly to typical asthma therapy. Okay, so you got to diagnose it, what you're dealing with first. Okay, now you have a patient who's 60-year-old, came in with cough, shortness of breath, crackles in upper mid-lung, and then so you do chest X-ray. Chest X-ray shows interstitial infiltrate and infiltrate, and CT shows diffuse micronodules and fibrotic lung changes in upper lobes bilaterally. Okay, so they'll ask you what caused these issues. Okay, what caused those symptoms? Okay, what causes it is silicosis. Okay, this is how you know what causes these issues. So this is silicosis. Now this brings a discussion of silicosis. When does that happen? How does it happen with coal mining, somebody sandblasting, construction? There could be acute or chronic silicosis. Acute, usually within weeks to few years after exposure. You see basilar alveolar filling pattern without rounded opacities, poor prognosis with cyanosis, cardiopulmonary, respiratory failure, less than 4-year survival rate. And there is a chronic, usually develop over 10 to 30 years. The X-ray shows you nodular opacities, irregular in the mid and upper lung zones, like in this patient. You can have nodules to form or severe respiratory symptoms or cardiopulmonary. Okay, and there's accelerated atherosclerosis. This one, silicosis, this is within 10 years, okay? Increased risk for lung cancer, mycobacterial disease, scleroderma, rheumatoid arthritis, causes chronic bronchitis as well, okay? Okay, there's something to think about. Okay, now we have another patient. Young guy, 24-year-old, have wheeze, asthma-like symptoms, asthma-like symptoms, shortness of breath, nasal congestion, demonstrate inhaler technique, it's fine, everything is okay with her. FEV1 shows restrictive pattern though, okay? FEV1 over FVC causes like 0.9, okay? So restrictive pattern. So what's best next step? Here you're lacking the flow volume loop, so you want to do repeat spirometry with the flow volume loop. And then you could ask yourself, why do we need to do that flow volume loop? Because this could be vocal cord dysfunction. And the reason this happens, usually after psychological stressors, like depression, exercise, post-operative, if there's GERD, irritant, smoking, cleaning chemicals, and usually develop respiratory stridor, wheezing, dyspnea, cough, dysphonia, throat tightness, choking sensation, okay? And the way you diagnose it, pulmonary functions could be normal. So what you would do, you do flow volume loop, you see flattening of inspiratory loop on flow volume curves, and you do laryngoscopy, you see vocal cord dysfunction. This is very hard to diagnose. This is very important to pay attention to. Only the lower part would be flat, the inspiratory. The expiratory part is going to be fine. So unlike upper airway obstruction, both are going to be, the upper and lower would be flat. But this one, the lower would be flat, the upper would be peak. Okay. Now another case, 47 woman came in with chest pain, dyspnea, okay, diagnosed with PE, right? Finished 3 months. So how, the question is, what would you do right now? Like she has a PE and she was given Eliquis for 3 months, okay? PE after cholecystectomy. She was given PE for 3 months. So this has been treated, right? So 3 months, what do? You continue anticoagulation or discontinue? So what the plan is to discontinue anticoagulation. So why 3 months is enough, okay? So there are risks now. This brings us to a discussion of a risk factor for venous thromboemboli. Usual surgery, trauma, immobilization more than 3 days, pregnancy, estrogen, active malignancy. There are other things that cause emboli, like inherited thrombophilia, like factor V laden, prothrombin gene mutation, protein C and S deficiency, antithrombin 3 deficiency can cause that. Other thrombophilia like antiphospholipid syndrome, paroxysmal nocturnal hemoglobinemia, polycythemia vera, nephrotic syndrome. These can increase risk for thrombosis. Okay. In this patient, there was a surgery is gone, risk factor is gone. So 3 months can discontinue. Okay. If there is somebody still have the risk factor, then you do 6 to 12 months. Okay. If somebody had like recurrent, okay, you don't know what's causing, could happen again, then you give them lifetime. Okay. Okay. Another important kind of high yield case is interesting. So 60-year-old after had cabbage surgery, right? After cabbage, started having shortness of breath and chest X-ray shows raised left hemidiaphragm. Okay, restrictive pattern on PFT. What could be best next step? What could be your diagnosis here? So here after cabbage you can have something interesting. It's called phrenic nerve injury. So you wanna, the way you diagnose it, you do fluoroscopic, sniff test. Okay. So the other thing that causes so unilateral diaphragmatic paralysis is more common than bilateral paralysis. Okay. Okay. So with the sniff test, when they do it, okay, normal diaphragm moves downward during inspiration, and the paralyzed diaphragm moves paradoxically upward movement. Suppose it go downward. Okay. So this moves upward. Okay. Other causes for diaphragmatic paralysis like viral, herpes, polymyelitis, tumors, spondylosis, neck surgery, trauma, idiopathic, a bunch of things can cause diaphragmatic, phrenic nerve injury or diaphragmatic paralysis. Okay. Now the guy, 23-year-old, work night shift, sleepy. Okay. What's best next step? You give modafinil. It's shown that is helpful for somebody with excessive daytime sleepiness. Okay, so there are a bunch of things that causes daytime sleepiness. Somebody who doesn't sleep enough at night time, poor sleep hygiene, you just improve their sleep hygiene. If there's obstructive sleep apnea, you do CPAP, weight loss, and avoid supine sleeping. Okay, if there's narcolepsy, like severe daytime sleepiness and hypnagogic hallucinations or disrupted nocturnal sleep, like working at night, if there's cataplexy, you give them stimulants like modafinil, venlafaxine, fluoxetine, atomoxetine, sodium oxybate for cataplexy. It's helpful for narcolepsy patients. Alright, other things that people who sleep a lot, eat a lot, and do a lot of sex, usually in teenagers, there's no effective treatment for that. You're screwed. This is weird syndrome. It's called Kleene-Levin syndrome, recurrent hypersomnia. Anyway, I think it's low yield for the exam. Alright, now we have patient end stage COPD, decreased breath sound, pursed lips, like this patient is having PCO2, 51. What's best next step? You refer for hospice care. Okay, this is kind of important too. And then you want to know which one eligible for hospice care, like if somebody severe, irreversible chronic lung disease, somebody have disabling dyspnea at rest, FEV1 less than 30%. This is extreme stuff, okay? And advanced lung disease. Other things are progressive end-stage lung disease, increased number of emergency visits, multiple hospitalization. Then in this case, maybe you want to make them comfortable. They're getting tortured. Hypoxemia, like PaO2 less than 55, or PO2 saturated pulse oxygen 88. If there's hypercapnia, like PCO2 more than 50. If there is right heart failure from pulmonary disease, if there is unintentional weight loss, more than 10% of body weight over 6 months, if there is resting tachycardia, these criteria make you eligible for hospice care or palliative comfort care, Okay, now another patient, a 28-year-old, came in with fever, joint pain, shortness of breath, crackles, nodules on legs, okay, bilateral upper lobes opacities. And what is the diagnosis? This is clearly sarcoidosis. When nodules on the legs, this is erythema nodosum, and then upper lobe infiltrate, this is consistent with sarcoidosis, okay? So there are 4 stages for sarcoidosis. Like the first one is a bilateral adenopathy. You can have paratracheal node enlargement. This is very specific. Second stage, usually upper more than lower, like bilateral hilar lymph adenopathy and reticular opacities in the upper lobe more than the lower. Third stage, reticular opacities mostly in the upper lobe and shrinking hilar nodes. And in the fourth stage, reticular opacities and volume loss, mostly in the upper lobe. So the more upper it is, the more dangerous, more end stage it is, okay? Now, another high yield case that you would want to know, it's very important. If you see somebody 44, had cough, sore throat, mild myalgia like 3 days ago, now come in with shortness of breath, with exercise at night, cough as well at night, what do you do for this patient? Just give them LABA, long beta 2 agonist, LABA or SABA, okay? You can do SABA. SABA is good actually. Why? Because this is called acute bronchitis. Usually there is viral illness, and then they come to you with cough more than 5 days for 3 weeks, plus minus purulent sputum, they may not have it. If there is absent systemic findings, like there is no fever or chills, wheezing or rhonchi, chest wall tenderness, you can see that as well. How do you diagnose? You do clinical diagnosis, chest x-ray when pneumonia is suspected, or pneumonia is suspected. You do symptomatic treatment, like there's NSAID or bronchodilators as well, you can do that. So just symptomatic treatment, no antibiotics needed for this patient. This is just acute bronchitis, post-viral. It can happen, okay? Nothing to worry about. Alright, now we have another case. It's kind of interesting and sad case. It's easy, I think easy to figure out. Like you 23-year-old male or female, weight loss, poor energy, rhonchi, and over the upper lobe. And then you do CT, you see right upper lobe bronchiectasis with fibrotic changes, pancreatic calcification and atrophy. This is cystic fibrosis. So what is best next step? You want to do sweat chloride test. This is unfortunate, like there is a mutation in the sweat chloride channel. It affects everything, so it causes bronchiectasis, pancreatic insufficiency, meconium ileus, salt depletion, metabolic alkalosis, obstructive azoospermia as well. So to diagnose one or more clinical features or history of cystic fibrosis with a sibling or newborn, positive newborn screen, sweat chloride more than 60 on 2 or more occasions, 2 cystic fibrosis mutations, nasal epithelial ion transport, like potential difference, abnormal ion transport. Okay, this could indicate that. Okay. Now another case, it's kind of interesting. It's also important in high yield that you want to know. Alright, so you have a 37-year-old woman, okay, comes in with shortness of breath, and then when you examine her, you see hollow systolic murmur at left sternal border, okay, left sternal border increase with inspiration. So this means mostly tricuspid rigor. There is lower extremity edema, okay. So you do pulmonary function test, okay. We do PFT. You see diffusion capacity 64%. Normal is above 80% of predicted. So there isn't good diffusion. Diffusion capacity is pretty low. Okay, but other FEV1 over FVC is like 97. There's some restrictive pattern you can think of. FEV1 is 80%. Okay, so they ask about diagnosis. So they tell you basically which one that causes FEV1 to be restrictive pattern and the LCO would be low. This case is pulmonary hypertension, primary pulmonary hypertension. Okay. Other features of primary pulmonary hypertension usually causes syncope, chest tightness, angina, abdominal distension, early satiety can happen as well. You do hollow systolic murmur from tricuspid rigor, like in this patient. They can say loud P2 from pulmonary valve, JVD, ascites, edema, hepatomegaly can present. And the FEV1, usually the difference is in obstructive lung disease versus restrictive lung disease. Restrictive lung disease, FEV1 over FVC will be increased, okay, and COPD would be decreased. That's the main difference. And the forced vital capacity will be low in restrictive lung disease, but in obstructive lung disease will be normal or decreased. Okay, so that's kind of important to know. Okay. Okay. Okay, so another case scenarios that could present as well. Somebody they give you, okay, someone have pneumonia, it's been treated 45, had pneumonia, been treated, what's best next step? Nothing. Okay, the only time you want to intervene if somebody has more than 20 pack years smoking history or 50 to 80, okay, then you want to do a CT. This one, even if it's a smoker, you don't do a CT. You do CT to rule out malignancy, go do a CT scan. Okay, that's kind of the idea. Okay, another case scenario they can bring is, so okay, 55-year-old came in with pulmonary nodule. Okay, so you do CT scan on chest X-ray. So you do CT scan, shows 2 centimeter spiculated nodule with punctate calcification at the periphery of the right upper lobe. So what is best next step here? You do best next step here, you do surgical wedge resection. Okay, so solitary pulmonary nodule, if they are large, patient with advanced age, female sex, active or previous smoking history, family or personal history of lung cancer, upper lobe location, speculated radiographic finding, this possibly, you know, it's you need to just take it out, you know. So nodule classified as rounded opacity less than 3 centimeters, surrounded by pulmonary parenchyma and no lymphadenopathy. Okay. Okay, if it's more than 0.8, we could be concerned. But if it's like 2 centimeters, that's pretty concerning. Okay. Okay, here you have a 28-year-old woman, pregnant with asthma, right? So what would you do? Best next step. You want to do scheduled mometasone formoterol twice daily, okay? Because if she's taking it as needed, she need to take it daily, you know? It's just like treat it as same as asthma in normal people. So severe asthma prior to pregnancy, or obesity, interstitial weight gain, smoking during pregnancy, these are all increased risk factor for pregnancy. Okay, asthma, pregnancy asthma and pregnancy. Symptoms: cough, wheezing, shortness of breath, precipitated by respiratory infections. Complications could complicate to preterm delivery, low birth weight, antenatal hypoxia. So the treatment: smoking cessation, reduce environment triggers. You do inhaled steroid beta 2, intermittent or scheduled if it's persistent. We do systemic steroid for acute exacerbation, okay? Don't be worried about that, okay? Because you don't want to have hypoxia to the baby, okay? Okay, now someone with ARDS, okay? So what do you want to do? Like somebody with ARDS, they give you a setting, okay? pH 7.29, PaO2 65, PaCO2 is 54, and they tell you, okay, what's best next step? What setting? They bring you all this kind of setting: increase respiratory rate, decrease dietary volume. Which one? What do you do? Or continue, same thing. So the answer is continue, same setting. Why? Because everything, if you look at it, is at target. You look at the pH 7.29. We want it between above 7.25. So this is good. PaO2, we want it between 55 to 80. This is 65. That's good, you know. PaCO2, it's 50. It's good. Respiratory rate less than 35. It's good. Plateau pressure less than 30. PEEP is 5 to 15. It's good. Tidal volume is like 6 milli per kilogram, you know. So everything continues same setting until we're able to, they pass SPT, RSPI is good, so then we stop. Alright. Now we have a patient who's 68, man, comes in with shortness of breath, dyspnea, hollow systolic murmur at left sternal border, hyperinflated lung, diffusion capacity, DLCO, is 37, so severely depressed, right? Lots of blood going to the lung. So in addition to smoking cessation, what would you do? Like his pulse ox 88, okay, so what do you do best next step? This guy is in a bad situation, so you want to give oxygen. So this brings us to a discussion: when do you give oxygen? If the PaO2 less than 55 or home oxygen less than 88, okay? If it's the resting, or if the resting PaO2 less than 59 and saturation less than 89 plus core pulmonale like erythrocytosis, hematocrit more than 55, or right-sided heart failure, okay? This patient clearly have right-sided heart failure, so the cutoff is less than 89, then you do something about it, okay? Another case you can bring as well, somebody with choking sensation at night, BMI 39, best next step, do sleep study, okay? Perfect, now we summarize what we learned, like really quick. So we talked about sleep study for nighttime choking sensation. We talked when you do give oxygen for COPD patient, the setting for ventilator setting is important. How do you manage asthma in pregnancy? Surgical wedge resection for nodule that's high suspicion of malignancy. Someone with pneumonia and young patients, you don't need to do lung cancer screening. Primary pulmonary hypertension, we talked about that. Sweat chloride, okay, for somebody with cystic fibrosis. SABA is good if somebody have shortness of breath, sore throat, like had a post-viral for acute bronchitis, you know. You want to do sarcoidosis management. You want to know if there's upper lobe, upper lobe opacities, the sarcoidosis. Know when there's hospice care needed. Sniff for narcolepsy. Sniff test if there's a elevated hemidiaphragm, okay. Discontinue decoagulation after 3 months if the trigger is gone. Flow volume loop to diagnose vocal cord dysfunction, women need ENT as well. Silicosis, if there's fibrotic lung changes, micronodules, the silicosis. Methicillin challenge test if there's like nighttime dyspnea, PFT normal, you know, you do that. IgG, it's recommended if there is like bronchiectasis, because if it's low then you can replace it, it may help. Hypersensitivity pneumonitis if there's a crackles, clubbing after radiation or so. I found antrypsin like a young patient have emphysema. Okay, and that concludes our discussion for last section of the pulmonary system.